All right, it's 5 past, so I think we'll go ahead and get started. So my name is Mark Zonfrillo, and I know many of you on the Zoom. I am in the departments of emergency medicine and pediatrics, and I am the co-director of the research practice and policy core of the COBRE, along with Lindsay Orchowski. And today I'm going to be talking about coding and mapping injury severities or injury diagnosis and severities. Let me share that here. Okay, can you guys see that okay? All right. All right, so I'm going to talk a little bit first about the International Classification of Diseases, or ICD injury codes, and then I'm going to define the Abbreviated Injury Scale as a lexicon of injury that's actually been out for a long time. It's gone through many revisions, and we'll also be discussing the Injury Severity Score, which is a composite score based on the AIS, or Abbreviated Injury Scale. And then I'll be discussing mapping strategies for ICD to AIS. So notably, I will not be discussing sort of other non-mechanical, thermal, or chemical injuries. The focus here is going to be on those injuries that can be categorized using the Abbreviated Injury Scale score. So some examples of the ones I won't be discussing are things like, or won't be included in this discussion and at a high level, are things like brain hemorrhage from a stroke, or a brain injury from like a tumor, things like insect bites, even though they're technically in the injury category of the ICD lexicon. Poisonings, again, even though they're sort of in the broader injury category, they're not a mechanical or thermal injury. The only exception to that would be if there's some type of like caustic burn resulting in a burn. I also won't be discussing injury mechanism today or injury intent. Injury mechanism can be captured using health records and administrative databases. But I'm just going to be talking about the anatomic injuries. Intent, whether an injury is intentional or unintentional, I will also not be discussing. I also won't be covering physiologic parameters. So you'll see in the literature a lot of physiologic parameters, things like blood pressure, or Glasgow coma scale, but will not be covering those. And I also won't be looking at functional outcomes. So, you know, things like physical and cognitive disability following injury. Although all these things are of great interest to me. Actually, my K award was looked at functional outcomes following injury, but I'm going to be focusing just on the anatomic lexicon of injuries today. I also won't be talking about sort of alternative injury severity proxies. There have been some that have been created that are composites of both anatomic and physiologic parameters. So it's sort of like, okay, I have a brain injury, I have a bleed here, and the patient, you know, had a low blood pressure or was hypotensive. We won't be talking about that. There have been a number of sort of alternative injury severity proxies and lexicons that have been developed for a specific project or study, but they're not widely used or adapted or validated. So I'll be focusing just on ICD and AIS, which I'll talk about in more detail. So ICD is the International Classification of Diseases. It was developed by the World Health Organization to assist in looking at causes of mortality, and includes codes for various diseases, disorders, and injuries. So the current version of ICD is ICD-10, so it's the 10th revision. It was mandated, well, it was like delayed for a few years, but I think it was mandated around like 2013 to 2015 in the United States to be used exclusively. And it was preceded by ICD-9 for many years. The there are about 68,000 ICD codes that cover all diseases, disorders, and injuries, and about 16,000 of those are injury related. And we'll talk a little bit about why there are so many. So this is a listing of the broad categories of ICD injuries. And you can see here, they're pretty much by body region. Of note, as I mentioned, the ones at the top are all body region. And then you can see some that are effects of foreign bodies, burns or corrosions, frostbite, things of that nature. And if we dive into a subcategory of these, so if we just look at injuries of the head, that first one, you can see that there are many injuries, many codes for various types of qualifiers. So a superficial injury of the scalp can be unspecified. And then you have qualifiers based on whether or not it's the first encounter for that injury or a subsequent encounter or a sequela of that injury. And this is why there are up to 16,000 injury-related ICD codes, because you get very, very specific with the number of codes. Of note, we won't be talking a lot about ICD-9, but there were only about 1,900 or 2,000 ICD-9 related injury codes, which provided some challenges when you wanted to understand, in particular, injury severity. So the abbreviated injury scale is the internationally recognized system for injury scoring. It was created and has been updated by the Association for the Advancement of Automotive Medicine. And just to take a little sidestep, so AAAM, as it's colloquially called, was founded in the 1960s, and it was by physicians who were caring for drivers of races who were injured, and saying, hey, what can we do to kind of prevent some of these injuries? Well, fast forward over 60 plus years, and it's an international organization. About half are physicians and half are doctorate level PhD members. And the physicians are either trauma surgeons or emergency medicine physicians. And most of the PhDs are either biomechanical engineers, but also some epidemiologists and behavioral psychologists. And they work together in an interdisciplinary fashion to focus exclusively on road traffic safety. And it's awesome. I mean, it's a really great organization. And it's great to go and sort of analyze injuries, road traffic injuries, from all different lenses. And AAAM created the abbreviated injury scale score. And it was introduced in 1970, and it was originally for vehicle crash investigators, but has been now applied more broadly to all types of injury. And the latest version that came out was AIS 2015. There's a new version that comes out about every 8 to 10 years with updates in between those. And most importantly, it's an anatomically based system, and it ranks injuries according to severity on a 6-point scale. And this is important when we consider injury severity. So this is the snapshot from one of many pages from the AIS manual, and we're going to dive a little bit into what this means and how to assign and then use these AIS scores. So you can see here, this is these are scalp injuries just on this page, and you have different subsets of scalp injuries: abrasions, contusions, lacerations, etc., and then subsets of those with different types of qualifiers. So we'll talk a little bit about what those individual codes mean that correlate to those injury descriptions. And just of note, the AIS is a code book, it's a lexicon. And so every possible mechanical injury has an AIS that is available to be assigned to it. So what the AIS does not include is suspected injuries, possible injuries, probable injuries, or ruled out injuries. So you have to be very confident and definitive that you have injuries that are confirmed. It also doesn't include medical sequelae. So let's say you get an injury and then you get a subsequent infection, or you subsequently die, from the injury itself, or have other sequelae like blindness, miscarriage, epilepsy, a pulmonary embolism. These are not included in the AIS coding or the injury severity, and they don't affect the severity score of the injury. So again, anatomically based injuries, not talking about any physiologic factors or any sequelae. So the severity score is every code, every AIS score has a severity score, and it ranges from 1 through 6, where 1 is a minor injury and 6 is a maximal injury. And here are some examples of progressively severe injuries to the liver. So an AIS 1 injury would be something that's minor, so you're just going to have a bruise to the abdomen. Other examples of AIS 1 injuries would be things like cuts to the skin, or scrapes, abrasions. AIS 2, also known as a moderate injury, and again, an example of a liver-based one would be a small liver laceration. Other examples of AIS 2 injuries would be things like long bone fractures, especially if they are non-displaced or just broken but in place. AIS 3 is considered serious, and that's when you would have something like a liver laceration with more than 1 liter of blood loss. And you might say, well, wait a second, I thought you just said that no physiologic sequelae. The only one that's related to this, or the only 2 that are related to the AIS score, are blood loss, because it indicates a more severe injury. And then when you're talking about head trauma, things like coma. But aside from those 2 things, it's purely anatomic. AIS 4, a ruptured liver, that would be a severe injury. AIS 5, a critical injury, so a liver laceration involving the hepatic vessels. And then AIS 6, which is a maximum injury, like an avulsed liver. So it was originally created as a threat to life in an average person who sustains the coded injury as his or her only injury. So if you to isolate any other injuries that someone has and says, okay, the only injury that they have is a liver laceration that involves the blood vessels, how severe is that injury? And these were originally created as expert driven, but over time, and I was actually involved in the last iteration of this, they've become more data driven, which is great because we have larger databases now, and we can look and actually see sequelae. And over time, the threat to life has changed. An injury that may have been fatal 40 years ago may not be now, or it may be more treatable. And when it says here an average person who sustains the coded injury, there are some qualifiers in the AIS that are related to age. For example, something like a lung contusion or a rib fracture. If an 80 or 85-year-old gets a lung contusion, a bruise on their lungs, or a rib fracture, it can be very serious. But if an 8-year-old gets the same injury, there's usually no sequela of that. And so there are some age-specific qualifiers for AIS. So as you saw in the dictionary, I showed a page before when we were looking at some of the head injuries. Here's 2 examples of the AIS injuries. And so one is the femur, a fracture of the femur, of the shaft of the femur. And this would be complex or comminuted. Comminuted means broken up into many different pieces, or segmental. And then the second example is a subdural hemorrhage of the cerebrum, of the main part of the brain. Large, massive greater than 50 cc's or milliliters, or greater than 25 cc's if the age is less than or equal to 10. And so you can see here, it's a 7-digit code. Well, what do these codes mean? Well, the first 6 digits are called the pre-dot codes. And then the single digit after the dot is called the post-dot code. And for the pre-dot codes, if you see here, this corresponds to a body region. So all the head injuries correspond to a body region of 1, which is why you see here this cerebrum subdural, and then this corresponds to an extremity body region. The digit after the dot is called the post-dot number, and that's important because that indicates how serious the injury is. And so we have we have 6 body regions, but we also have 6 severity categories, which I mentioned before. And then you can also have a 9, which indicates the injury is present, but there's no severity value. And I'll talk about examples of those. So example from the state registry, a concussion with a loss of consciousness less than 30 minutes. You have this 6-digit code, and these all correspond to different qualifiers that aren't pertinent to this lecture. But this 1 is the body region, so that's the head, and the 2 here is the severity. So that's a 2 out of 6. An example of an injury that is present, but there's no severity value, would be something like a closed head injury initial encounter, or unspecified injury the head initial encounter. You know where the body region is, you know it's the head, you know it's an injury, but there's not enough information there in order to code it. And this brings me to the important point to make, is that AIS is considered in very conservative terms. So unless you can determine that an injury actually existed, then you can't code it. And B, unless you can determine with some level of precision or confidence what the injury was, then you can't usually code the severity. And here's a case of that where you cannot code the severity. There are also some qualifiers that appear throughout the dictionary and allows for coding of injuries when detailed information is lacking. And those would be the not further specified. I'm going to talk a little bit about how you get those details, but if for some reason you don't have them, then it defaults to not further specified. Again, it's conservative coding, and so you would either code it less severe than you would if you had the full details if you don't have them, or not assign it severity code at all. Just a note about AIS 6 injuries. AIS 6 is not used just because a patient dies, even though it's a maximal injury. It has to be documented medical evidence of an AIS 6 injury. So, in other words, not all AIS 6 injuries are necessarily fatal. Many are, but they don't have to be. And just because an individual patient may die from an injury doesn't mean that it's automatically AIS 6. So here are a number of examples of AIS 6 injuries. I'm not going to go through them all, but as you can see, these are very severe injuries of either, the spinal cord, the carotid artery, the heart, the aorta, the liver, severe burns, more than 90% total body surface area. So it's really, you're assigning an AIS 6 based on these, predetermined categories in the lexicon. But just because someone dies doesn't mean that it's an AIS 6 injury. And if someone survives but has one of these, it can still be coded AIS 6 in severity. So that's all of a setup to the injury severity score. So what the injury severity score is, it's a composite score. It is an overall score for patients with multiple injuries. And so there's a process by which you create an injury severity score. And the first step is to assign each individual injury an AIS score based on the handbook. Injuries are sorted in 6 body regions, which are listed here. And those become important. And I know it can be a little confusing because there's 6 injury severity categories and 6 body regions, but those are distinct. So how do you calculate the ISS? Well, the first step is to determine, the scores of the individual injuries using an abbreviated injury scale. So, and then you want to identify the highest severity score in each body area. And so again, these are the body areas used for the injury severity score: head, neck, cervical spine, face, chest and thoracic spine, abdomen, the contents of the pelvis and the lumbar spine, extremities and the bony pelvis, so the bone of the pelvis itself or the bones, and then external injuries, including skin injuries and burns. And so here's an example of a patient who has 7 injuries in 4 different body regions. So they have 2 injuries to the head, 1 to the thorax, 1 to the abdomen, and 3 to the extremities. And you can see here that, once you have these injuries documented, you can assign AIS codes to them. And in this case, as with every injury, you have a code that's assigned to every single injury. So what you then want to do is look at the most severely injured, the highest injury, the injury with the highest severity in each body region. So you can see here the head has 2 injuries, one with the post-dot code of 5, that's from 1 to 6, and the other one with a post-dot code of 3 from 1 to 6. So the 5 is the most severely injured one. The thorax only has 1 injury, so you include that. The abdomen only has 1. And then of the 3 extremity injuries, again, the one with the highest post-dot code is 5. So step 1 is I assign AIS codes to all of the injuries. Step 2 is identifying the highest AIS or the most severe injury for every body region. And then you want to square the highest score in each body region. So in this case, 5 squared is 25, 3 squared is 9, 3 squared is 9, and 5 squared is 25. And then to calculate the ISS, you take the highest AIS squared from 3 different body areas. So the ISS is only the composite of the 3 most severely injured body regions. And if there's a tie for one of those or more, then you just kind of pick one because you can only have 3 body regions within the ISS. So in this case, it's kind of a dealer's choice here between the thorax and the abdomen because the head has a max AIS of 5, which squared is 25. The extremities has a max AIS of 5, which is 25. And both the thorax and the abdomen have a max AIS of 3, which is squared is 9. So you take one of them out. And then the ISS here is 25 plus 9 plus 25, which is 59. Okay. The ISS, and here's a second example. So this is one of there's only 2 injuries. There's only 1 injury in each body region. And it's a, pretty straightforward equation here. It's 2 squared plus 2 squared, which is 4 plus 4, which is 8. So the ISS or injury severity score ranges from 1 to 75 in patients who have 1 or more injuries. You can get a maximum of 75 2 ways. The first would be if you have a maximum of AIS of 5 in 3 different body regions, since 5 squared plus 5 squared plus 5 squared is 75. The second is if you have an AIS 6 in any body area, that defaults to an ISS of 75. Now, what's really important to keep in mind, and if you take away anything from this lecture, is that there are multiple mathematically impossible ISSs between 1 and 75. Because if you square or you sum the squares of up to 3 different numbers, where those numbers are 1 to 6, there are many mathematically impossible ISS scores, including, for example, 15. You cannot get the number 15 from summing the squares of, you know, three of those numbers. And therefore, when you use ISS in looking at a proxy of injury severity or controlling for injury severity, you have to use medians and interquartile ratios, or you can use ISS ranges and categories. I review a lot of papers where authors will use means for ISS, but it's inappropriate because it's not a continuous variable. And so just keep that in mind. Here are some common ISS categories that are used when categories are used. And as you can see, you know, this is a rough proxy to, you know, what the max AIS score might be. Some patients have multiple injuries, but many may only have one. And so as you can imagine, an ISS of 1 to 4, 5 to 14, sort of mild to moderately injured patient. And then once you get over 15, and especially over 25, that's a more severely injured patient. You're also going to have the frequency distribution of patients with these ISS scores goes down significantly the higher you get. In other words, most patients have lower severity injuries. So I'm not going to go through all of this, but the point is that it's important to get a lot of granular injury detail. And these can be obtained in a number of different ways, which I'll discuss in the subsequent slides. And the reason for that is because the more detail you get for your injuries, the more precise your AIS is going to be. And you'll also be minimizing misclassification of injury severity. Because if you don't have as much detail, then your AIS scores are not going to necessarily reflect reality, and you'll have misclassification, and you'll have scoring of patients whose injuries are less or appear to be less severe than what actually happens in reality. So where do you find AIS or ISS? Well, there are very few places where you can actually find them. Trauma registries have them. So trauma registries are sources of data needed and used for comprehensive public health surveillance. And so trauma registries can be found at trauma center hospitals, like Rhode Island Hospital has one overarching registry for all the patients who come to Rhode Island Hospital, and then also the patients who come to Hasbro Children's Hospital. But those trauma registries are often limited to pre-hospital survivors. So if you die at the scene from an injury, you're usually not going to be put into the trauma registry. Even if you're brought to the hospital with, no signs of life. And also injuries requiring admission. So if you're on the playground and you fall and you break your humerus and you go to the hospital and you get a cast put on and you go home, yes, you were injured, but you weren't injured so severely that you're admitted to the hospital. So those trauma registries won't capture those patients. So the way that these trauma registries work is that there's an accreditation process by which hospitals are accredited to be a certain level trauma center to be able to care for patients with certain severities of injury. And the highest level, or the type of trauma center that can care for the broadest and most severely injured patients, is a level 1 trauma center. And Rhode Island Hospital is a level 1 trauma center, and Hasbro Children's Hospital is a level 1 trauma center. So by virtue of being a trauma center, these trauma registries collect, as part of their information of patients who are in the trauma database, abbreviated injury scale score and injury severity score. Okay. So the institutional trauma registries, which I mentioned, like Rhode Island Hospital, Hasbro Children's Hospital, there's also statewide trauma registries And then there's national trauma registries. The most common one is the National Trauma Data Bank, which is from the American College of Surgeons. So the ACS is the governing body over the trauma registries. And in order to be an accredited trauma center, you have to meet all of the criteria. There's a certification process, there's a certification renewal process, there's a site visits to ensure that you're meeting, this sort of like comprehensive criteria for being able to care for patients with injury. And part of that is the reporting of patients from your trauma registry that have that are injured. And so the National Trauma Data Bank is actually available. You do have to pay a fee and sign a data use agreement, but it's available. And I've used it for multiple studies to study patients who are injured and go to trauma centers. Now, there's a bit of a spectrum bias there, or selection bias, because these are more severely injured patients and ones that end up at trauma centers. But that being said, it is a very systematic and rigorous representation of the patients that are included in it. The National Highway Traffic Safety Administration also has databases, a number of road traffic injury related databases, which again are specific to road traffic injuries, and those also have AIS. But notably, you usually can't find AIS or ISS anywhere else. Most electronic health records don't have it. Most administrative databases don't have them, and there are a number of administrative databases, large databases that are available for free or for a small fee that are either related to consumer products or focused on patients who present to the emergency department or patients who admit to the hospital. None of them have AIS or ISS, and that can be a challenge if you want to do injury-specific related research. So what do we do? Well, then we're going to have to map injuries. And because ICD codes are readily available, there needs to be a strategy by which you can map ICD to AIS and ISS for the purposes of controlling for injury severity, specifically as it relates to injury-related research. Now, I'll preface this all by saying these mapping options are not perfect, but that is understood to be the case because by design, the ICD codes may not be specific or granular enough for the purposes of mapping because they don't capture all of the ways that AIS and ISS codes are traditionally abstracted. So we helped to develop a map that mapped ICD-9 and ICD-10 codes to the AIS. This was the 2005 version with the 2008 update. And the reason for this is because there were a number of proprietary and publicly available mapping systems available to convert ICD codes to AIS codes. But they were limited by using older versions of ICD or AIS, most notably the ICD map 90, which stands for 1990. It was a map that was has been used, it still is used, but literally for over 30 years. Just to give you some perspective of how old it is, the original map used to, you pay $50, you send a check, and they will send you 6 floppy disks that you install in your computer, and that was the map. And also that version of the map was based on ICD-9 and older versions of AIS. Also, some of these maps were sort of folks who just went rogue and may or may not have had the appropriate training, experience, and knowledge of both ICD and AIS to make valid maps. So this project was completed by over 14 experts who developed the maps and knew the intricacies of the two coding systems, the ICD and the AIS. And the point or the objective was to develop maps for both ICD-9 and ICD-10 to the AIS, that version of AIS. And they spent hundreds and hundreds of person hours looking at these maps, looking at the codes and generating the maps. And they developed a priori rules for mapping the injury codes. So of note, they couldn't map everything because there were some examples of severity scores of 9, which is something that was unknown or non-mappable. Like the example I included before, that sort of nondescript head injury where you can't map the severity because you don't have enough information. So over 19,000 ICD codes were analyzed, about 16,000 from ICD-10 and almost 3,000 from ICD-9. And then maps were generated for each individual code to chapters, severities, and body regions. So about 3/4 of the ICD codes were assigned an AIS severity score. The remainder were assigned a severity score of 9 or non-mappable. And then about 80% of the codes could be mapped to a chapter and a body region. And so this is a screenshot of an example of the map. So, this is 6 codes out of the, well, in ICD-10, 6 codes out of the 16,000. And you can see here that it has the maximum AIS severity, the body region, and the AIS chapter. The chapter is just the chapter in the manual, and the body region are the 6 body regions that I mentioned earlier. So all of these happen to be very low severity, literally superficial injuries of the head or scalp. The body region is 6 because that deals with the extremities and external, and the chapter is 1 because it's in the head. But for the purposes of the AIS, we just use the AIS, the max severity, and the body region. So the conclusion of this study was that mapping between ICD and AIS provides this expert designed solution, and then by applying these rules, they created these definitive maps, which are the only ones endorsed by AAAM, which again is the governing body of AIS. And they also conclude that future work should include verification of these maps for MIAS and ISS estimations, which large data sets. And so we sought to do exactly that. So we wanted to map, we wanted to validate the map to see how much agreement there was between kind of the gold standard of data abstraction and assigning AIS versus a mapped AIS based on ICD codes. And so we also wanted to compare it with that of the older version of the map, the AIS map 90 that I mentioned before with the floppy disks. And because that has been used for, again, over 30 years with hundreds and hundreds of articles. So we wanted to see how the newer map fared compared to that one, which has been widely used. But obviously, the newer map has updated versions of both lexicons. So we actually got patients from pediatric and adult patients from Harborview Medical Center. It's a large injury-specific hospital, trauma-specific hospital in Seattle. And one of the reasons we chose them is because we want one with a higher volume than our own. And also we want to ensure that the AIS codes that were assigned for that trauma registry were done in sort of the traditional, rigorous, approved way, which is abstraction of health records by a certified coder. And that's how they assign the AIS scores for the purposes of their registry. And so in addition to that, we had up to 20 ICD codes for injuries. And then we looked at the highest AIS for any given body region, and then the composite ISS score. And we used the traditional or the standard body regions there. So we had, each patient encounter had two set of values. We had the abstracted records, which is the maximum AIS and the injury severity score from expert coder medical record review and abstraction. I won't go into detail how that's done, but that's, through certification, you look at everything. You have to look at operative reports, radiology reports, notes, all of those things to A, identify injuries, and B, identify details about those injuries in order to assign with confidence AIS codes. So that's sort of the abstracted method. And then there was the mapped method, where we just purely took a grid of all the ICD codes related to injury, and we mapped them using the previously mentioned map. The abstracted ones were used as a gold standard for comparison because it was the gold standard by definition. So there were just under 35,000 ICD-9 codes and just under 2,000 ICD-10 codes. Of note, this is because the mandate for use of ICD-10 occurred just a year or two before this study took place. And so that's why there was a difference there. Harborview Medical Center sees patients of all ages, and so you can see the age range there with the median age in the 40s, and then the percentage of codes unmapped. So this table looks at paired ICD-9 and ICD-10 codes. We have the number of injuries, and then the maximum AIS agreement of abstracted versus mapped codes. And then we have the 6 body regions. So what does MAS agreement mean? Well, it means, okay, if you have, let's say you have 3 head injuries, and you have assigned AIS scores for all of those. Maybe one is an AIS 2 severity, one's a 4, and one's a 5. Well, you're going to say, well, for those 3 injuries, the maximum AIS score was a 5. That's based on my abstracted data. Now go to the mapped data. Okay, we have 3 different injuries, ICD codes, the first ICD code, the second, and the third. And then you're going to map those to AIS scores, and you're going to see what the max AIS score is from those mapped. And so we looked at the percent agreement. And so these are here's the distribution of the number of injuries and the percent agreement. You can see here that the highest percent agreement was face for the ICD-10 codes, 86%, and extremities for the ICD-9 codes at 80%. The lowest agreement was actually head and neck in both of those. And I can discuss later if we have time to a hypothesis, as to why that's the case. And in just comparing ICD-9 and ICD-10, just out of curiosity, even though we're sort of shifted to the ICD-10 in general, most of them were similar. The biggest difference or discrepancy was in the face, where 53% agreement for the ICD-9 and 86% agreement with ICD-10. So now this is comparing the former map, the ICD map 90, and looking at the same agreement based on the study that was done, 34 years ago now, and then looking at ours. And what you can see is that there's, across the board, it's actually pretty similar. About 50% for head, neck, face, 60% for thorax and abdomen, 70 to 80% for extremities and external burns. And so the level of agreement for the newer map, which is based on the newer versions of ICD and AIS, compared to the old map from 30 years ago, that's been used again for hundreds of articles, hundreds of publications, is pretty similar. Then we wanted to look at exact ISS agreement. So that's the composite injury severity score, and for ICD-9 and ICD-10. And we see that exact AIS agreement is about 50% in each sample. But then if you have a little bit of range in there and say, well, exact ISS plus or minus 5. So just as an example, let's say the gold standard abstracted ISS was 16 in the, for a certain patient. But then the mapped ISS was somewhere between 11 and 21, then you would capture 76% of those patients had an agreement within that range for ICD-9 and 71% for ICD-10. So when you're talking about different categories of ISS, as I mentioned earlier, you're going to get pretty good agreement with, okay, yes, this is likely in the ballpark of some type of categories of an injured patient. Of note, when we look at the McKenzie article, again from 30 plus years ago, the level of agreement, again, was similar. About 70% had an exact ISS of plus or minus 5. And then finally, this one looked at different categories of ISS. So of those who had an abstracted ISS score of 1 to 4, 5 to 14, and on, what was the agreement? And the bottom line is that there was stronger agreement for the less severely injured patients. This is probably for a few different reasons, but it's just important to know that, when you're applying and using this tool, for example, if you're going to be looking at just very severely injured patients, you have to take into consideration the validity and reliability of this tool, because it doesn't perform as well for the most severely injured patients if you're looking for an ISS agreement. So some limitations: this was a single institution. Again, it was a much smaller ICD-10 sample. It only includes the max AIS and ISS body region. It doesn't have that full 7-digit AIS score, which is probably okay if you're just wanting to look for injury severity. I think the important thing to remember is that it's not meant to replace manual coding of abstracted medical records for detailed AIS surveillance. So that's definitely a limitation here, is that, because it's not, the level of agreement is not extremely high, you have to take that into consideration. So the conclusions for this study is that recently developed maps can reliably be used to assign maximum AIS, and there's some comparable agreement to that of the existing frequently used map that's been used for decades now. So in summary, ICD has specific injury-related diagnoses codes. AIS is a comprehensive lexicon of anatomic injury diagnoses. ISS is a composite score of AIS, and ICD and AIS maps can be used where traditionally abstracted AIS scores are not available. I want to thank everyone for your time, and I'm happy to take any questions. And it looks like there's also a poll before you leave.
Mark, that was great. I don't know that I have a specific question other than to say that I'm embarrassed that I've never actually sat down and picked your brain about this before. Such an interesting way of looking at all of this, and with some of the limitations of just looking at the ICD coding, this is a great addition to doing research. I'll mute and I'll ask my questions in the text so my child does not contribute.
Okay. Yeah, no, I thank you, Steph, for that. I appreciate and eager to see your question. I mean, I think that, again, like I mentioned, I review a lot of articles where people will use AIS or ISS, and it have uh, doesn't pass the gut check in terms of like, I'm like, I'm not sure they really understand, how to use this in when doing analyses. The other thing is, a lot of people will just make up lexicons, you know what I mean? And it can be a little challenging to try to compare, to try to review papers like that or grants or things like that, because you know, uh, just creating your own lexicon of injury severity without validating it, there's a lot of challenges there. And I could talk about this stuff all day. I actually have a lot of thoughts about, how can we leverage electronic health records and multi-center just patient registries in general to optimize the injury severity derived variables that we can use for the purposes of injury related research. I was just on another call, regarding a proposal for PCARN, which is the Pediatric Emergency Care Applied Research Network. They have their own registry of patients, and they have the full record of the patients. It's really robust. But it would be great to think about, okay, are there ways we can create some derived variables for injury severity for the purposes of including those in those databases and other national databases, so that if someone wants to use them for the purposes of injury related research, those injury severities are already kind of baked in and available to them. And we just have a couple minutes left. I see Steph typing, I think, so I'm gonna wait. Okay, so Steph says, given that coding is entirely dependent on how well we document, how do you take this into consideration when you interpret ISS? That's a great question. So I think that because trauma registries are mandated to optimize an accurate and comprehensive AIS, and a lot of the anatomic qualifiers are captured with diagnostic imaging or surgical notes or sometimes autopsies. But because of that, you can be pretty confident for patients who are in trauma registries that their ISS are going to be accurate and optimized. However, as I mentioned before, for patients who are discharged, for patients who don't make it into the trauma registry, you're going to be challenged for getting an accurate ISS, whether you're abstracting the data or you're mapping it. And what's interesting is I'm looking at an analysis now of comparing ISS in rehab data versus trauma registry data, because we know that the trauma registry data, the ISS is going to be optimized, but in the rehab data, you're not going to have all of that granular injury related information. And so we know that there's going to be misclassification. In fact, I've shown that there's misclassification, whereas if you don't have a data set or a database or a registry where you're mandated to collect this granular data in a very systematic fashion, you're going to have misclassification where the true severities of the injuries are going to be higher than what you're capturing. So it's a really great point. All right. Well, I think, so I'm happy to talk offline. You can send me an email. Thank you so much, everyone, for joining. And we'll see you next week. I think next Wednesday at 2 p.m. Tanisha Wilson will be giving the next COBRE related talk. Thanks, everyone. Take care.